Hi, everyone. Thanks for joining as you're trickling in. We'll give folks a few minutes to pop in um, before we get started. Right. In the interest of time, because I know everyone's donating their evening, and I'm really appreciative of everyone being here on a night like tonight, I think we'll get started if that's okay. And Angel, if you're ready, I'll go ahead and share and we can get started too. Alrighty, folks. How's that looking, Angela? Okay, fantastic. So my name is Dr. Gabriel Cartagena. I am a clinical psychologist and the clinical psychologist for not only Smilow, but the Yale Psycho-Oncology program. Angela, you want to introduce yourself?
Sure. Hi, good evening, everybody. My name is Angela Khairallah. I'm a clinical social worker. I am also the Smilow Oncology Social Work Manager. So glad that all of you were able to join us this evening.
We're incredibly grateful to have you all here and to be talking with you guys about this important topic today. We want to get started by acknowledging always that we make a really strong effort to align with our talk with Smilow's core values, which is an emphasis on the integrity, the respect, and the compassion of people, which is why we're actually bringing up such an important topic today. And as our title suggests, and I want to go back to the title for a moment, our topic is going to be on self-harm and cancer, risks, realities, and pathways for support. And as the title suggests, our conversation will involve discussions about self-harm and suicide and the realities of that experience, which can often elicit strong emotional responses or even distress itself. And it's never easy to talk about these sorts of things, which kind of makes it all the more important to be able to talk about them. So if during this presentation you find you are in need of support or heightened care, we encourage you to please take care of yourself and connect with emergency services listed here. But let's get started and talk a little bit more. But let's start broadly because I just mentioned the idea of distress. But
One
when I
thing,
say,
Gabe, just want to
yeah,
remind everybody that this is being recorded. Sorry about
oh,
that. Thank you. Go
yes,
ahead, Gabe.
like all Smilo shares to disseminate for folks so that they can watch after the fact, use this information, tell it to their friends, use it in the future. The talk is going to be recorded. Thank you so much, Angela. But I mentioned before, distress, it's a word we often hear from others. We see it on TV. We might hear it from our providers, but what does it actually mean? Well, in the context of cancer, psychosocial distress is often defined as a multifactorial, unpleasant experience of a psychologic nature, and that could include cognitive, behavioral, emotional, social, spiritual, and or physical that may interfere with the ability to cope effectively with cancer and its physical symptoms and its treatment. And despite it being unpleasant, as I mentioned before, it's actually a very common experience for people who are undergoing treatment or are on the cancer journey themselves. And it can make it all the more difficult to cope with the diagnosis and everything that comes with it. It can evoke feelings of sadness, anger, frustration, and even ultimately affect the way that we think, feel, and act. Now, cancer in and of itself can really impacts some of the most important relationships that we have in our lives, as well as how we take care of ourselves, how we react to other people and connect with other people. However, distress ultimately can look very different for everyone, and it can ebb and flow throughout the cancer experience, going from severe symptoms to mild and anywhere in between. It can affect not only our mood, but also our faith. It can emanate from changes in our bodies to changes in work and finances. And so it's a very unique experience for every individual. I mentioned it's a common experience, but just how common is it? In the general population, we might find that about 1 in 3 people will experience psychosocial distress, but up to 75% of people living with cancer have reported experiencing it in their journey. And those numbers are pretty alarming, but they make a lot of sense overall. That distress is a normative experience and a normative response to an impossible situation. And preliminary research has really found that distress can vary based on cancer site and type, with some of the highest prevalences of distress being in breast cancer and head and neck cancer survivors in some of the research that we've done so far. And distress can often become so overwhelming and feel so out of control that it ultimately severely impacts our well-being. And this happens in the general population, but it also happens disproportionately for people who are living with cancer. And unfortunately, what we know now is that the risk of death by suicide for people living with cancer is as much as 2 times higher than the general population. And that's an alarming statistic given what we know about the current burden of suicide in the United States overall. The cancer journey in and of itself is so full of different changes, different turns, adjustments, that distress ends up looking very nonlinear. There's no one singular point in which distress kind of just appears and hits you. And suicide and self-harm are also unique experiences for people who are in survivorship, people who are at end of life, or people who might be at the very beginning of this diagram where they just got their diagnosis. It might look different for every individual. And so I've been mentioning these concepts, these terms, suicide and self-harm, but as we move forward, it's going to be pretty important and helpful to define the terms that we often hear. And so self-harm is also known as self-injury, and it's the act of harming oneself purposefully, but not always with the intention of death. Non-suicidal self-injury is another term that you might hear used by providers or you might hear on TV, again, with the act of self-injury without the ultimate intention of death. Well, suicide is death caused by injuring oneself with the intention of death. And suicidal ideation, which we may often have heard of before, includes thoughts or rumination or preoccupation regarding death by suicide. And we often talk about it in 2 different forms. One of them is active, and so it's the thoughts, the rumination, the preoccupation, also accompanied by a concrete plan, or passive suicidal ideation, which includes the thoughts, the rumination, and the preoccupation, but accompanied by no motivation to live, but no plan specifically for any harm. So as I mentioned before, that we found in our research that people living with cancer are at disproportionate risk of self-harm and suicide. But in a sweeping study occurring in the United States across almost 2 decades, we found that about 20,800 people died by suicide, people who were living with cancer, I should say, and we had found those numbers to be pretty consistent to present day. In such studies, we've also found things like race and ethnicity, marriage status, insurance status, socioeconomic status, all contributing in some way, shape, or form to increase a person's risk for self-harm, particularly if they are undergoing cancer treatment or in part of their cancer journey. We've also found so far that the highest risk overall for suicide and self-harm occurs within the first 6 months of a diagnosis, at which point the risk at that point becomes 7 times higher for people living with cancer than their counterparts. What we know now is that quality of life, or even one's expectations of their quality of life, are really crucial. And we often see higher risks for different cancer types that really affect quality of life. Although cancer affects quality of life ubiquitously across each cancer type, we find that oropharyngeal cancers, GI cancers, lung, breast, and brain cancers often yield higher risks of suicide and self-injury. Though these results are really staggering, the undercurrent is quality of life. It becomes really difficult to imagine what quality of life could look like because cancer relentlessly changes so much of one's life. And ultimately, one's quality of life becomes central, and a life worth living becomes incredibly important, but hard to imagine. So as we do this research, what sorts of risk factors do we start to identify? Some risk factors, other than the ones I've mentioned so far, include a recent stressful event that's kind of compounded the cancer diagnosis, such as a loss. additional chronic pain or an additional physical illness, age, middle-aged men in particular, and those over the age of 85 have some of the highest rates in this population. Gender, men more than double the rate of suicide and self-injury than women in every age group. Ethnicity, including American Indians and Alaska Native individuals, as well as histories of trauma, substance use, as well as mental health diagnoses, particularly those that have been undertreated. Additional risk factors might include a history of psychiatric hospitalizations, previous attempts, previous ideation, a lack of support system, as well as these feelings of shame, despair, hopelessness, helplessness that are deeply embedded and feel really difficult to navigate. Now, I've been talking for a while about risk factors, and that's an important thing for us to reflect on. But one of the other most important things that we also need to nurture and discuss are protective factors. And these are the factors that help promote mental health and physical health and ultimately help curb suicidal ideation. So some of these include your ability to live independently, to do tasks and different things that are meaningful to you in an independent way. Good self-regulation skills. That might mean the ability to come face to face with a curveball, whether it's a stressor at home or a stressor interpersonally, and find different ways to be able to cope and regulate your emotions as you go through each of these challenges. Identifying key reasons to live, whether it's the roles that you play in life or the things that you really like to do. Identifying specifically reasons to live and move forward is incredibly important as a protective factor. Being receptive to change and flexible as things come up is also incredibly important. We've also found that cultural beliefs and religious beliefs, particularly those that discourage aggression, have been found in the literature and the science to be really beneficial and protective when it comes to these matters. Some additional protective factors that we found include active engagement in treatment, which can be really hard to do and is kind of a double-edged sword when we're thinking about distress. Communication to any standard is a really helpful thing and a protective factor. Good social engagement, having a robust social support system, but also connecting with people, at least having one point person that you might be able to turn to and open up to, ask for guidance, even spend time with, even if you're not asking for guidance, that's incredibly important. And the literature has also told us that things like fear of death and having a supportive other, whoever that other might be, as I was alluding to before, can really be protective when distress starts to feel insurmountable. So through research overall and the work that we've done, we've begun to learn more about what puts people living with cancer at risk for self-harm and suicide. But none of this is really valuable unless we're doing something with that data, unless we're doing something positive and helpful with the information, which means listening to people's struggles, identifying ways to intervene, ways to ask questions, and then finding ways to help and guide individuals toward resources. What we do with this information matters, and no one should suffer in silence. And so luckily, I have my colleague here who'll tell you more about what we do as providers and as a hospital to make that happen.
Thank you, Gabe. Again, it's such an honor to be here tonight and talking to all of you about such an important topic that I can definitely say Gabe and I, it's near and dear to our hearts, and we feel very passionate about this. And but as Gabe was just alluding, we don't want our patients to have to suffer in silence. So here at Yale at Smilow Cancer Hospital, we do have a variety of tools that we use to help screen for patient psychosocial distress. And it's not only because we're striving to implement the best practices and provide the highest quality of care that we can to our patients. The most important piece to this is that we care about you. We care about our patients. We want to know how you're doing. We want to know how we can best support you from the moment that you're diagnosed throughout your cancer journey, through survivorship, and even at the end of life. And so with that, over the next several slides, I'm going to be just discussing the different various ways that we have been and currently are screening for patient psychosocial distress. I just want to point out, though, before I get started, that distress screening is actually meant to be an initial step in more targeted evaluation of the source or the sources of a patient's psychosocial distress. And screening cancer patients for distress, again, is not only best practice, but it's so crucial because it really allows us to identify those psychological and emotional difficulties that can significantly impact your quality of life, your adherence to treatment, just overall your well-being, It also allows us to have timely interventions and provide appropriate support through counseling, social work referrals, referrals to psycho-oncology, and ultimately leading to better management of your cancer experience. So with this slide right here, there are different institutions throughout the nation that have recommendation standards for distress screening. And so the three that I have listed here are the National Comprehensive Cancer Center, commonly referred to as NCCN, the Commission on Cancer, referred to as COC, the American Society of Clinical Oncology, which is referred to as ASCO. And all three of these institutions have recommendations that cancer patients should be screened for distress using a validated tool. Next slide. Thank you. This is just kind of a timeline of where we started and where we are now. Clear back in 2019, we started utilizing a screening tool called the distress thermometer. And actually, there are a variety of service lines throughout our Smilow network that are still utilizing the distress thermometer. So this was launched in 2019. And initially, it was on an iPad for the Smilow Breast Center, the Guilford Care Center, and the Torrington Care Center. And this distress thermometer was given to patients that were newly diagnosed. Unfortunately, it came to a stop in March of 2020 because of the pandemic. It started up again throughout the system using a paper distress thermometer, which is still continuing in a variety of service lines again throughout the network. We did some, we got back together and decided we wanted to go for something called an ASCO certification program. And because of that and the different things that were required, we switched from using a distress thermometer to using the PHQ-2, which is a tool that's used to screen for depression, and something called an SDOH, which is the social determinants of health, to screen for healthcare disparities. There are a variety of institutions, including the Joint Commission and the Center for Medicare and Medicaid, as well as ASCO, that around this time we're recommending that healthcare systems also screen for healthcare disparities. So with that, in January 2023, the iPads were launched again in the Smilow Breast Center and the Guilford Care Center, this time using the psychosocial distress of the PHQ depression screening and then the social determinants of health screening. And then now in 2024, it's moved to Trumbull, Orange, and the North Haven GI. Next screen, please. This screen right here might look familiar to some of you because this is the NCCN Distress Thermometer, National Comprehensive Cancer Network. Again, this is still being utilized in paper form in a variety of different service lines throughout the network, although the hope and the goal is that we are going to eventually shift to have iPads hopefully available throughout everywhere where we are using the depression screening, the PHQ-2, as well as the social determinants of health. You can see that a patient will score themselves between 0 and 10, 0 being no distress, 10 being extreme distress. And then on the right-hand side there, you can check off the different areas of distress. Oftentimes, if the patient is checking areas for emotional, social, practical, and even sometimes spiritual concerns, they'll get referred to social work. Often it's a 4 or above that would then get you referred. Next slide, please. I also want to highlight that in 2019, the Joint Commission implemented a regulatory requirement that conducting depression screenings that when indicated, a suicide assessment or screening should also be utilized. And so in January 2023, Smilow again began handing out those iPads in a variety of areas in which patients were given the depression screen, the PHQ-2, and depending on how patients scored on that, it then they are given 7 more additional questions, which is referred to as the PHQ-9, which I will be talking about in a few slides. But if a patient scores a 1, 2, or 3 on question number 9 of the PHQ, which is actually a question that asks those really important questions about self-harm, thoughts that you would be better off dead, hurting yourself. If a patient answers positively to that question, they're considered high risk and they need to have a separate suicide assessment and screening. And here at Yale New Haven Hospital, we are using something called the Columbia Suicide Severity Rating Scale, or referred to as the CSSRS. Next slide. One of the other reasons why we decided to use the PHQ-2 for our depression screening is because it is an ASCO recommendation. And so they really recommended that this is the most reliable and validated tool that can be used to assess for depressive symptoms. And so again, we follow this process. A patient is initially given the PHQ-2, and if they answer a 2 or above on either of the questions, they then get 7 additional questions, which becomes the PHQ-9. I want to point out that it's estimated between 25 and 30% of patients will have to complete those additional 7 questions. And again, the last question on the 9 is a question that asks about thoughts of self-harm or thoughts that you felt like your life would be better off if you had passed away. And it's important to note that among these patients who have moderate to severe depression, thoughts like this are actually not rare at all. Next slide. This is what the PHQ-9 looks like, okay? And so the first part of it is the 2, and then the second half of it is an additional 7 questions, which makes it the 9. And if you want to move to the next slide, we're going to look at it a little bit more closely. So this is the PHQ-2 depression screening. So basically, it asks patients that over the last 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. So if a patient answers 2 to either of these questions, then they're going to get 7 additional questions, which becomes the PHQ-9. And that's my next slide. Go ahead. Thank you. So questions 3 through 9 make up the PHQ-9. And again, that question number 9 is highlighted with those red arrows. Thoughts that you'd be better off dead or hurting yourself. If a patient answers 1, 2, or 3 on that, we actually have a workflow process to address this immediately that I will get into in just a moment. Next slide, please. It's pretty common that when I'm talking to patients, they often wonder what the scores mean on the PHQ-9. And so this is the breakdown of what it means. So depending on how somebody scores, it allows us as practitioners to have kind of a baseline of maybe where your depression might be at. And again, it's just one of the many tools that we use to help determine how you're doing. But if someone scores between a 0 and a 4, it's thought often that they might have none or a minimal depression. 5 to 9 is mild, 10 to 14 is considered a moderate, and then 15 to 19 is considered, or actually 15 and above is considered moderate to severe. Next slide. But here at Smilow, this is how we look at the breakdown of the scoring. Again, if a patient scores between 0 and 4, we see it as maybe none or kind of minimal depression. A patient between 6 to 14, where it's mild to moderate depression, our process is that the patient should be referred to a Smilow social worker for further assessment and evaluation and determination of what supportive services are needed. If a patient scores a 15 or above, that's considered moderate to moderately severe depression. And if a patient is not connected to a mental health provider in the community and is interested, they can be referred to our psycho-oncology team, which is the team in which Gabe works with. And unfortunately, though, right now the services are only available if a patient is in active treatment in New Haven, North Haven, or Guilford. And then, of course, the patient scores positively to that question number 9, which is the one about thoughts that you'd be better off dead or hurting yourself. If they answer 1, 2, or 3 to that, there is a workflow process in place in which social worker is contacted immediately, and they're asked to meet with the patient and complete a psychosocial assessment, which will involve the suicide screening, the Columbia screener, and possibly a safety plan, depending on how the assessment and screening go. Next slide, please. Just a little bit of background of why we use the Columbia Suicide Severity Rating Scale, or the CSSRS. This is a reliable and validated tool, okay? And back in 2016, to respond to the increase of suicide rates among the United States, something called the Columbia Lighthouse Project was formed through Columbia University. Dr. Kelly Posner was part of this effort, and it was developed to help support suicide risk through a series of very simple, plain language questions that anyone can ask. In fact, my understanding is in New York City, they often train police officers and firefighters on how to utilize these simple screening tools. And I love that their motto is just ask, you can save a life. And so it really is about encouraging anybody to utilize these tools. But it helps to identify whether someone is at risk for suicide, and it helps to determine the severity, the immediacy of the risk, gauge the level of support that the patient needs at that time. And then there's a variety of questions that get asked, ranging from whether or not they were having thoughts or ideation, all the way down to if they've had any attempts in the past, or if they're currently thinking about having an attempt now or have a plan in place. Next slide, please. This is just to highlight to you that's part of our hospital policy at Yale New Haven Hospital, that if a patient is considered to be at moderate risk, that we administer the Columbia suicide risk screening with them, and as well as put safety planning in place. It's important to note that any licensed provider within the system can actually administer the Columbia screener. It doesn't have to be a social worker, it could be a doctor, an advanced care practitioner, nurse, but it often is the social worker at Smilow that will reach out and complete the Columbia screener with the patient. Next slide. This is what the Columbia screener looks like. I wanted to show this to you so that you had a sense of what kinds of questions are being asked. But it really starts off by just asking, have you ever wished that you were dead, or wished that you could go to sleep or not wake up, all the way down to, have you ever done anything or started to do anything or prepared to do anything to end your life? And again, depending how somebody answers these questions, there's low, moderate, and high risk. And a social worker will take their psychosocial assessment that they've completed, the ratings that are on the Columbia screening tool, as well as look at your risk factors and your protective factors to help determine whether or not a safety plan should be created with you. Or if you're such a high risk, maybe helping to reach out to a family member or friend to get you to the emergency room for further evaluation, or possibly help call 911 to get you to an emergency room as well. Next slide, please. This is what a safety plan would look like. So in the event that you're talking to a social worker and they think that it would be beneficial and helpful to create a safety plan with you, these are the types of things that they'll be asking you and be writing up and providing to you. So starting again with different warning signs and things that you might have that can trigger you to start having those thoughts of self-harm, or thoughts that your life would be better off if you were dead, all the way down to, internal coping strategies, or people and settings that can help provide you with distractions, people in your life that you can reach out to for help, if there's any professionals or agencies that you can reach out to. But one of the most important things that I want everybody to make note of today is that by texting 988, that is the National Suicide Hotline, and they are available 24 hours a day, 7 days a week, 365 days a year. And that is a resource that you can reach out to at any time, day or night. Next slide, please. This is just some data that we have related to the iPads that we are giving out, like I said, in the Smilow Breast Center, the Guilford Care Center, Orange Care Center, Trumbull Care Center, and then in the GI North Haven Clinic. So between October 1 of 2023 to August 31st of 2024, I just want to point out there was 12,400 patients, so 91.9% of the patients completed a depression screening using an iPad. And of those patients, 492 or 3.9% scored a 9 or above on the PHQ depression screening. And out of those patients, 99 or 0.7% answered yes to the self-harm question. So next slide, please. And I just want to highlight here tonight that really the purpose of us screening you for suicide, the purpose of us using this Columbia screener, it's not to predict if someone will act on their thoughts, but it really truly is for us to do the very best job that we can to increase your safety, to help reduce your risk, and to provide you with care and support. And the most important thing for us is to provide a safe place for you to discuss your struggles and know that you are absolutely not alone. We care about you, and we want to make sure that you have the resources that you need to help you with any sort of distress that you might be experiencing. Next slide, please. So within the Smilow system, we have a variety of supportive services to help patients manage their psychosocial distress. So one of which is social work, which I'm representing here tonight. And we provide a variety of services ranging from supportive counseling to support groups, support for bereavement. We provide a resource called Parenting at a Challenging Time. So how parents can talk to the children about a cancer diagnosis and treatment, resources for survivorship, financial counseling, supportive resources, community resources. When we have psycho-oncology, and with our psycho-oncology service line, it's really an interdisciplinary approach. We have social work involved with that, psychology, nurse practitioners. They provide individual counseling and treatment. It typically is about 6 to 8 sessions. Really with psycho-oncology, it's really about helping you with distress, anxiety, depression that you might be experiencing as a result of your cancer and your treatment. We do have cognitive behavioral therapy groups that we do periodically offer to patients. Cognitive behavioral therapy is learning about how your thoughts, your feelings, and your behavior all kind of connects together and how to help you cope and manage as you're moving forward. Again, it's important to highlight, however, that currently right now, psycho-oncology is only available in the New Haven, North Haven, and Guilford care centers for patients that are being treated there in active treatment. The other resource that we also have available that some of you may have been referred to is something called a community health worker. And again, the community health worker services, hopefully they will be able to be expanded throughout the care network, but right now they're only available in the Smilow Breast Center, in some of the Guilford service, and some of the services within the Guilford Care Center, in the Orange Care Center, North Haven GI, and Trumbull. And patients that are referred to community health workers, they help with things like medication support, support related to insurance issues, maybe a patient struggling with medication access. They provide you with different resources in the community. They assist with navigating the healthcare system. They have, maybe different financial resources that they can refer you to. So they are a very good resource as well. So you have these 3 different areas that are available to you throughout, the system that can help provide you with support. Next slide, please. So I've been spending time talking about social work. And so I want to make sure, though, that all of you know what kinds of services oncology social workers provide and what exactly it is that we do for you. So we're all licensed professionals who provide supportive counseling, emotional support. We help you gain access to resources and services, not only for yourself, but your family, your caregivers, those of you who are impacted by your cancer. We provide we provide education. We have skills in helping you identify the social, the emotional, the physical, the spiritual issues that can impact you because of cancer and treatment, not only at the time of diagnosis, but through treatment, a recurrence, progression, survivorship, palliative care, and even at the end of life. Next slide, please. So these are the different locations in which we do have social work services available: Greenwich, Trumbull, Fairfield, Torrington, Orange, New Haven, North Haven, Guilford, St. Francis, Hartford, and social work services are also available in Waterbury, Derby, Waterford, Lawrence and Memorial, and Westerly. Next slide, please. And again, as Gabe highlighted at the beginning of this presentation tonight, there are a variety of different times in which we know social distress can heighten for patients. And it's important to note that social work services are available to you at any point in time across the care continuum, whether it's you're newly diagnosed, you're starting treatment, during treatment, there's been a recurrence, or you've had progression of disease, you're ending your treatment and moving into survivorship, you've been referred to palliative care, maybe you're starting to have those end of life or goals of care discussions with your provider. And of course, anytime something else might come up in life that could cause you distress, while you're going through cancer and treatment, know that social work services are available to support you during this entire process. Next slide, please. So within social work, oftentimes when you meet with a social worker, we're going to start off by doing an assessment, getting to know you and your family. We have a variety of things that we're going to be asking you about so that we can figure out how to best support you through this process. Of course, we have a variety of like resources and services in the community that we can provide to you. Oftentimes, patients and families are interested in supportive counseling. If you're in need of more than the supportive counseling that we can provide, we can explore possibly referring you to the psycho-oncology team. Again, depending on if you're being treated in the New Haven, Guilford, and North Haven area and are in active treatment, or we can look to refer you to a mental health provider in the community if you are in need of more maybe long-term mental health services. And another really big portion of what we do as social workers is we have a variety of support groups for different types of cancer that you can come and participate in. Next slide, please. So when you do meet with a social worker and we engage in a psychosocial assessment, these are all the different areas that we're going to be exploring with you. We want to know about your reaction to your cancer diagnosis and how you're doing with that. We want to know about your family. Who is your support system? Do you have children? Do you live alone? Do you live with extended family members? What are your social and community supports? Your mental status, if there's any cognitive issues you might be experiencing. What's your employment status? Are you currently involved with any legal issues? Are there any financial concerns that you're having? We'll talk to you about spirituality if you're interested, if there's any sexual issues that might be impacting you. We always think about and keep in mind if you might be experiencing any new signs or symptoms of anxiety or depression. That can also often be quite distressful for patients if they've never experienced depression or anxiety before. It's often one of those silent side effects of going through cancer and treatment that sometimes gets often overlooked. And so it's important for us to know how you're doing. We're going to think about, do you have a mental health history? Have you had any exposures to any traumas or any violence in your past? We're going to talk to you about, if you've ever experienced any suicidal or maybe homicidal ideation, any thoughts or plans of self-harm in the past. Then again, we might be then exploring doing that suicide screening that we talked about, the Columbia screen, or possibly developing a safety plan with you. We want to make sure that you're safe in your home environment. We might ask you questions related to domestic violence or intimate partner violence, elder abuse, child abuse. But again, we want to just make sure that you feel safe in your home and with those that you are living with. And then most importantly, we want to know what your positive coping strategies are and what supportive factors do you turn to that help guide and support you as you go through care. Next slide, please. So it's important to know that social workers are part of your oncology team, okay? And we are available to assist you with a wide range of challenges that you or your families might be faced with while you're going through cancer. And, social work can be available to meet with you just one time, or maybe you're getting some really distressful news, and so you want that social worker to help go and support you while you're talking to your provider. We're available for that. Or maybe you're interested in seeing the social worker more often and having them stop by when you're coming in for your treatment. Again, really, it's all about what you need and what your preferences are with what types of services we provide. We can meet with you in person. We can speak with you over the phone. And some social workers on the team do have capacity to meet with patients through telehealth visits. Again, when we're meeting with you, we're going to be completing that assessment. And then also keeping in mind, if you have completed a depression screening, if you maybe the results of your social determinants of health, or even looking at your distress thermometer, all those things are going to help us have a better understanding of you and how to best support you. Next slide.
So one part of the larger psychosocial team that Angela was talking about earlier was psycho-oncology. And a psycho-oncologist might seem like a little bit of a wonky term, but it's essentially a licensed clinical psychologist with an expertise in the provision of mental health care for patients and family members who are undergoing cancer, are faced with this incredible challenge. this type of clinical psychologist is really trained to identify and support the emotional, spiritual, and psychosocial difficulties that individuals might face across the entirety of their journey. And they're also particularly skilled in intense, high need clinical cases where symptoms are incredibly severe. Some of the more like severe sorts of cases and symptoms that Angela was alluding to a bit earlier. And so that's what I am with regard to my role in Smilow and the expertise that I bring to the psychosocial care and the team overall. So when you work with a clinical psychologist, much like our social work colleagues, actually, when I'm reflecting on the things that Angela's brought up with regard to the approach that social work has, we really want to hone in on that history with regard to what you're coming in with and then what you're being faced with currently, right? So there's this idea that um, there are multiple different factors that you're coming into your diagnosis with, and we want to know about each and every single one of them to get a really good sense of where you've been and what different factors that might be contributing currently to your psychosocial distress or contribute to your current thoughts of self-harm. However, an assessment with a clinical psychologist might also include medical history, for example, medication history, what's worked for you, what hasn't worked for you, how those things are interacting with the treatments that you're getting right now. And then further work with you to talk about a diagnosis that they might see based on all the information that we're gathering together. And then educate you on what might be going on based on our perspective, see how you feel about that, and then suggest a potential treatment based on what we know so far to help improve your mental health. So when you work with a clinical psychologist, you might expect a few different things. The first one is that the first visit is really designed to gather your history and get a good sense of your experiences, particularly from your perspective. It's the opportunity for us to get to know you a little bit better and identify ultimately treatments that might help with your symptoms, as well as give you a good understanding of what could be going on, not to essentially like pull the veil or the curtain away from psychosocial distress that can often be there because it feels often very overwhelming and it's hard to put a name or a face to it. And then further, like to expand upon that, collaborate together on the fit when it comes to treatment, the goals for treatment, and how frequently we meet together to make those goals happen. And so similarly, visits can be conducted via telehealth with opportunities for in-person and via phone based on access and need. There's some flexibility there as well. And as Angela mentioned before, the treatment often spans 6 to 8 sessions, which in the literature shows us that especially if they're really goal-oriented and targeted, we can make some really great ground with regard to developing coping strategies that really help you through um, these more distressing moments and give you the skills that might be necessary to handle the adjustments and the shifts that might come throughout the process, as well as a mixture of supportive psychotherapy, which is this idea of having this space in which a professional knows not only the medical component, which is one of the really beautiful things about psycho-oncology, is an understanding, like a founded understanding of the medical component of what you're experiencing, but also the emotional component, which might often get lost in the details of all the treatments that you're getting and all the different providers that you're seeing. And so that mixture of both the goal-oriented as well as the supportive psychotherapy to help build your skills and give you the tools that are going to be necessary for you to live a life that's meaningful and worth living. And so together, social workers and psychologists really work to tackle psychosocial distress from many different angles because there's no one size fits all solution to how we take care of you. For some people, focusing on finances, for instance, and then help building up coping strategies and then talking through decision making might be the best combination for where they are right now when it comes to their cancer journey. And for others, it might look a lot different. Just like everyone's psychosocial distress looks different, not only in their body and their mind and in their personal experience, their mental health care can also look very different too. So now that you know a little bit more about what we do and how we screen for symptoms, how we provide support, and the different pathways that exist, it's important to know how to connect with our services. And so a first step can actually be talking to your medical team about a referral, which they can place and we receive pretty much immediately. However, you can also reach out to the psycho-oncology clinic number, which is listed here, as well as the Smilow Supportive Care Access Program, which is listed here, and the YNHHS Department of Social Work Service connection. And then finally, even if we have robust support systems and even if we have good service connection, we might still find that we struggle or that the people that we love or the people that we know are struggling too. If you or someone you love find yourself in an acute crisis and experiencing thoughts of suicide or self-harm and need that support, 911 may be a first line option to establish safety. Your local emergency room may be another option for an evaluation immediately. As Angela mentioned earlier, texting 988 to the National Suicide Lifeline is a really great option, as well as 211 if you have a Connecticut number to access a crisis mobile unit for evaluation. And that can also be a way to connect directly to support if needed. As we wrap up our talk for this evening, I'd really first like to thank the social work team at large for all the work that they do, as well as Donna Lapolte, who's an implementation specialist for Smilow and who gathers the fantastic data so that we can figure out how to use it to help people every day. And then I'd also really finally like to sincerely thank each of you, whether you're patients, listeners, community members at large, for taking the time to listen to us and be in conversation with us. I'd also like to preemptively apologize because we dug into the meat of the presentation. If there were questions in the chat, we're going to address them now, but we're also going to open up the floor for any questions that you might have for us after this presentation too. Thank you so much for listening. Let me see the chat. I don't see anything popping up in the chat. For folks who do have questions, if there is a question that is in your mind and you'd like it answered, or you just have something to ask, the chat is a great place to put it. We can moderate it. We'll give you a chance to think as well. It's a heavy topic and a lot of information.
And I just want to say thanks to everybody too for, joining us tonight. It's so nice to have all of you here listening to this very important topic. And thanks to you, Gabe. It was lovely presenting with you. So thank you.
It was wonderful presenting with you too, Angela, and working with you. It's awesome.
You too. I guess we can give it just a few more minutes, maybe, see if anybody has any questions.
Indeed.
I know with this being recorded, I believe it will be posted to our YouTube site. So this will be available to all of you to go back to and reference, to see if there was any additional information that you wanted to, maybe look at again or learn more about.
Well, I also don't want to keep everyone. I also want to recognize what Angela had just said, not only with regard to the fact that this information is still going to be available, posted such that it can be referenced to, used, reflected on in the future too. But the conversation doesn't stop here. So as we mentioned before, if there are any questions that anyone has further on, whether or not it's throughout their treatment, throughout visits, thank you very much for that. I appreciate it. Throughout treatment or visits,
Thank
um,
you.
always available to reach out to the clinic's numbers that are listed here in this presentation, as well as bring up this conversation with providers with regard to a referral. Again, the conversation doesn't stop here. Hopefully it's just the beginning. But thank you all so much for your time. We appreciate you immensely and hope that everyone is well and has a wonderful evening.
Thank you, everybody. And again, don't hesitate to reach out if you need anything at all. Ask to speak with, a clinic social worker and any of your medical providers would be happy to refer you for our services. Know that we are here to support you and your families as you go through this. So thank you for your time this evening. I appreciate it. And so with that, I guess
Wrap up.
we'll
Absolutely.
wrap up. All right. Thank you. Eliza, have you